Hi everyone, welcome to the future of drugs. My name is Jenny Valentish and I'm your host, and I'm going to keep the preamble so short because we've got so much that we want to fit into this session. So, things have been moving so fast in this domain after decades of stagnation, and we have three people who are at the absolute forefront to discuss all this tonight. And in the discussions we've had leading up to this, I just don't know how we're going to fit it all in, but you will have your chance to ask some questions at the end. Each guest tonight is an innovator in their field, so we're going to kick things off with a very quick presentation from each of them, from Sam, Ian and Marg, on what they're working on. Everything from new compounds to clinical trials to problem-solving existing issues with the drugs that are used in psychotherapy. So, first up is Sam Banister. Sam is Chief Scientific Officer at Psylo. It's an Australian biotech startup developing next-gen psychedelics to treat mental illness. Prior to this, Sam has held a number of academic appointments at Stanford and the University of Sydney, where his research was focused on the study of psychoactive substances and the development of new drugs to treat neuropsychiatric and neurological disorders. So, please welcome Sam.
Thanks so much for the intro, Jenny. It's great to see so many faces in person. Psylo, I'm Sam, I'm a medicinal chemist by training. I've been doing drug development work for about 15 years, as Jenny said, and I've left my academic appointments. I'm a recently laxed academic to start Psylo with my co-founder Josh, who's in the audience here today. And we're a biotech startup in Australia, sort of the only one of its kind, focused on using all of these understandings about psychedelics to develop next-generation medicines for very serious mental illness. So the reason that a lot of us are probably here and that everyone's so interested in this space is because of the effects of naturally occurring psychedelics like psilocybin. So based on the statistics, almost everyone in this room is going to have been directly or indirectly impacted by depression or another serious mental illness. And the reason people are so excited about psilocybin is because of these profound effects that these drugs are having in clinical trials. So this is one of the more well-known studies from a few years ago from Robin Carhart-Harris, looking at depression severity in a number of very severely depressed patients following a single treatment with psilocybin. So this isn't SSRIs, it's not a metformin or something that you take every day as an antidepressant. This is one treatment session with this profound mind-altering psychedelic substance. And what you see is a reduction in depression severity almost immediately, and one that persists for quite a long time, for many months. So there are a few issues with psilocybin. One is that it has a very long duration of action. So it's about 6 to 8 hours. You require sort of 2 therapists or psychologists in the room whilst the patient's being treated. It's not going to be scalable for the people who really severely need these treatments. And the other issue is not everyone's going to be able to access psilocybin. So there are a number of conditions or comorbidities that will preclude you from taking psilocybin in a controlled environment. And there's this really interesting idea emerging at the moment that maybe you don't need a full psychedelic effect, or perhaps you can have non-hallucinogenic agents that still have some of these rapid-acting antidepressant effects. So that's what we're really focused on at Psylo. And when I tell people I'm a chemist, you get one of 2 responses. The first is, can you make me drugs? Which I always sort of sheepishly laugh at and then say yes, but I won't. And the other one is, the other statement you always get is, I hated chemistry, which is always very, very pleasant for the line of work that you've chosen for yourself. So the reason that, I promise there's only a couple of chemical slides, the reason that drugs have effects in the human body and that we can create all these amazing mind-altering substances and medicines is because usually they look a lot like things that already exist in the human body. So I've got 2 very famous examples here, MDMA on the bottom left and psilocin, which is the active metabolite of psilocybin on the bottom right. MDMA looks a whole lot like this neurotransmitter dopamine that you've probably heard quite a bit about, and it interacts with a number of the same targets of dopamine. So these molecules are sort of hijacking innate endogenous systems that we already have that have evolved for various purposes. Psilocin is very closely related to serotonin, and hopefully even non-chemists can see that just from these simple structures. So it is possible to design new psychedelic medicines in a rational way using like a lot of the skills that I've developed over the last decade and a half. And as an example, I'd point out this very famous chemist here. Does anyone know who this is, by the way? A few hands go up, yeah. So Alexander Shulgin is a very famous chemist from California. He's most well known for MDMA. He's the person who sort of gifted MDMA to the world very early on. He was a famous chemist at Dow. He developed an insecticide for them called Zectran, and Dow gave him a very long leash after that because it made them a lot of money. And he decided what he was really interested in is the relationship between the structure of a psychedelic agent, which was quite new in Western science at that time, and its activity. So his first question was, taking mescaline from peyote cactus, which is in the top left here, what makes mescaline psychedelic, and are there better mescalines out there? So mescaline's fully active at about 300 milligrams, lasts for about 6 hours. Shulgin hypothesized that if you install this little methyl group in the top right structure here, I've shown it in pink, you might actually block some of the enzymes that metabolize mescaline. You might make it more easily able to get into the brain. It might interact with its target receptors a little better. He was right. You get a compound that's about 3 times the potency, lasts for a little bit longer. And then he asked, what happens if you start looking at the other end of the molecule and shuffling these methoxy groups around? You end up with something called TMA2, which is active at about 20 milligrams, lasts for about 12 hours. And just to take things to their fullest logical extent, he's also invented a series of DO compounds. DOB is a pretty famous example where you keep all of these previous features and you replace one of the methoxy groups with a bromine atom. And you end up with this profoundly psychedelic agent that is fully active at 1 milligram, lasts for about 30 hours. Probably not many people do it more than once, if at all. And really, this is just to highlight that we have a lot of mastery over the control of these drugs that we design in the modern age, and that we can design optimal psychedelic agents for medicinal use. Shulgin was doing this out of academic curiosity. He was doing it in the 60s and 70s and 80s before we had all of the modern tools in sort of neuroscience and chemistry. So Psylo is trying to build on this legacy of Shulgin and others to design sort of next generation psychedelic agents that are highly optimized for clinical use in a number of different indications. And we can take advantage of all of the latest developments in AI, molecular modeling, machine learning to achieve this mission and help a whole bunch of people who don't have very many good treatment options.
Thanks so much, Sam. Very exciting to hear about the work of Psylo. So next up is Ian McGregor, Professor of Psychopharmacology and Academic Director of the Lambert Initiative for Cannabinoid Therapeutics. The discoveries of his team around the use of oxytocin-like molecules to treat addiction and social withdrawal has led to the successful spin-off company, Kinoxis Therapeutics. Recently, Ian and his team have diversified into psychedelic research, and they're currently developing plans for a research program around psychedelic drug discovery, including a recently funded trial of psilocybin in the treatment of eating disorders. Take it away.
Thanks very much, Jen. Thanks, everyone, for coming out tonight. I'm actually a failed musician, if the truth be known. That's my real passion, but I wasn't very good at it. But yeah, I'm from the University of Sydney, just up the road there, and I'm the academic director of the Lambert Initiative for Cannabinoid Therapeutics. I guess the first question I've got for you is, why would you give cannabis to a child? You might give cannabis to a child because that child has an intractable form of pediatric epilepsy that is resistant to normal prescription medications. That child has tried every available conventional treatment and not benefited. And that was the story of Caitlin Lambert, a little girl with severe epilepsy called Dravet syndrome. And Caitlin's family found that giving an extract of cannabis to Caitlin had this remarkable effect. Basically, she stopped seizing. She became, to all intents and purposes, a normal, healthy little girl. And that gave rise to a great passion for medicinal cannabis from the Lambert family, who happened to be high net worth individuals. And they donated a large amount of money to the University of Sydney to set up the Lambert Initiative. And there's Caitlin there last year when she visited the university. And she's doing very well at the age of 10 and doing much better than a child with Dravet syndrome would normally do at that age. So she's a living testament to the power of cannabinoid therapeutics. The Lambert gift is all about trying to alleviate all sorts of human suffering through cannabis-based medicines. And we kind of know very little about the cannabis plant, although it's one of the most popular drugs in the world. There's more than 140 different bioactive molecules in there that we call cannabinoids. We know a lot about THC and CBD, but all the others are kind of a treasure trove that are yet to be exploited. But at the Lambert Initiative, we're also interested in building a better cannabis. Maybe we can go from the penny farthing to something like that. Who knows? And so we take these bioactive molecules from the plant and we tweak them, a bit like Sam is doing with psilocybin. and try to make more drug-like molecules that may have even better therapeutic effects than cannabis itself. And I want to acknowledge Sam Banister, who led our medicinal chemistry efforts for a few years before going off to his spin-off Psylo. So we do a lot of computational chemistry. We look at the effects of these drugs on receptors. It's all very molecular and very computational. We also have cellular and animal models of disease. We look at effects of cannabinoids on cancer cells. We have epileptic mice. We have fish with all sorts of afflictions that we can rapidly screen these molecules with. And then if we're very lucky, we'll get a molecule that we can then give to what I call the big rats. Human clinical trials. But often it takes 12 years to get a drug to the point where you can actually give it to a human being. So there are now a lot of people in Australia who are using cannabis medicinally. We had a legal scheme that started in late 2016. And for the first 3 years of that scheme, I got asked one question all the time: where the hell can I get some? People knew there was a scheme, but it was really, really hard to access cannabis. But access has become much better as the medical profession has become more aware of cannabis and more products have become available. So in the month of February 2022, we had more prescriptions for medicinal cannabis in the first 3 years of the scheme. So if you want cannabis, usually you can get it now. And there's more than 240 different medicinal cannabis products you can access: plant material, lozenges, oils, wafers, a whole smorgasbord of cannabinoid products. There's still entrenched skepticism from certain parts of the medical profession around medicinal cannabis. They don't think the evidence is strong enough. And this is the battle that we often do on a daily basis at the Lambert Initiative, to run clinical trials that will convince doctors that cannabinoid products have potential. We're also increasingly interested in what's called the psychedelic renaissance that Sam referred to. And as Jen mentioned, we have a trial that was actually funded by the Australian government. Isn't this amazing? The Australian government will actually put up cash for a clinical trial of psychedelics. That's unparalleled in the world. And hats off to Greg Hunt, who actually was a big fan of this kind of research. So anorexia nervosa, one of the most intractable mental health conditions there is. Nothing really works. So this trial plans to see whether psilocybin can reset the brains of people with this really severe mental health affliction. I'm also very interested in ecstasy. In fact, I spent about 10 years giving ecstasy to rats in a previous life. And when you give MDMA to rats, something really strange happens. They start cuddling each other. And these are two male rats that have never met each other before. And they just want to hang out and cuddle, and it's severely tactile and funny. And we did a lot of research on this, trying to work out why ecstasy has these amazing pro-social effects. But that actually gave rise to an incredible drug discovery story where, what is it? What's MDMA doing in the brain? And that took us to serotonin receptors, took us to the neuropeptide oxytocin, and eventually we came up with kind of an ecstasy that we thought might be safer than ecstasy itself, called KNX-100, and that was a 12-year story. And KNX-100 is potentially a universal panacea. It's pro-social, it makes you highly sociable, it's anti-aggressive, it seems to nip addictions in the bud. So when we give it to rats that are addicted to alcohol or meth or cocaine, they lose interest in drugs. It's quite incredible. It also alleviates drug withdrawal, and we've got our first human trials of KNX-100 underway as we speak, so watch this space. And interestingly, going back to MDMA, where the KNX-100 story started, it's now hitting mainstream availability, likely to be approved by the FDA in the next couple of years, particularly for PTSD. So very, very interesting times in this space. Thank you.
Thanks so much, Ian. And if you've got any KNX-100 on you, we'll talk later. Lastly, I'd like to bring up Dr. Margaret Ross. So Marg is Chief Principal Investigator and Clinical Lead for Australia's first psilocybin-assisted psychotherapy study treating depression and anxiety in the terminally ill. It's a world first. It's investigating psilocybin-assisted therapy for all palliative conditions, and Dr. Ross is pioneering a new frontier in psychedelic medicine. Thanks, Marg.
Thank you. And so want to thank Sam and Ian for leaving me 30 seconds to talk. Thank you for inviting me. So I'll stitch the thread together. We've got these two drug development gurus here working in research, and where I fit into this, what's a palliative psychologist doing here? I'm at the front line being able to implement this incredible combination therapy. So my name is Marg, I'm a clinical psychologist and I work in palliative medicine, have done for about 10 years at St Vincent's Hospital in Melbourne. So I'm the chief investigator of a psilocybin-assisted therapy study where we are treating depression and anxiety in terminally ill patients, and we are exceptionally privileged to do so. Many of you here know why psilocybin is of interest to us. For those of you who don't, psilocybin and other psychedelic compounds fairly reliably provoke quite intense personal introspection. So as a therapist, that is invaluable to us, and we really want to see if we can leverage that to maybe achieve deeper and longer lasting alleviation of suffering for depression and anxiety and other conditions. I'm not going to take too long, I promise. It's important to point this out. This is psilocybin in conjunction with psychotherapy. Okay, psilocybin as a dose is 1 day. We want to be able to leverage it and optimise it as much as we can. So we build psychotherapy into this treatment, so we're more likely to then leverage longer lasting effects on things like mood, cognition, thinking and behaviour. I'll talk a little bit about the structure of that, and perhaps if we've got a little bit of time later on, I can answer any questions that people might have and what a typical session looks like. In fact, we did one yesterday. We're about halfway through our study. Actually, no, we're more than halfway, and it's incredible work. I wish I could tell you more about it, but we're going to have to wait. All right, so just moving on there. What does it look like? I often get this question. That's my colleague there as well. So we work in a dyad. This is a dose day. For those of you who don't know what a dose day looks like, when you administer psilocybin in a treatment setting like this, you've got your patient sitting there, lying down on the couch, eye shades on, and headphones. They're listening to a very carefully curated playlist of music that mimics the mechanism of drug action, and it threads them through the psychedelic experience. Now, before we get to that point, we have done quite a bit of preparatory psychotherapy with them. We want to know who they are. We want to know their story, the narrative of their life, the narrative of their illness. We also want to do quite a bit of work around helping them face the psilocybin experience, because it's really intense. This is like nothing else that they have perhaps experienced in their talking therapy. They're in an altered state, and it can provoke very intense and quite challenging at times emotional states for people. So we have to teach them how to navigate that. That's a really important point, because that helps to mitigate the risk of having an adverse event. So we spend quite a bit of time doing that as well. By the time we get to the dose day here, yes, they're lying down. This is several hours. This isn't your usual psychotherapy where you roll up for 1 hour and you talk about your problems. This is several hours of being in an altered state and not knowing what's going to come up for you. So it's quite labour intensive, and it is really profound. It's very intense, and to say that we have been in tears many times witnessing quite incredible work that our courageous, incredible patients go through when they're in this situation it's an understatement. I've never cried so much in my life as a therapist. But it is intense for the patients. It's also intense for the therapists. So that's important to point out as well. We then spend quite a lot of time doing integration. So this is this is what, in a broad brushstroke way, what a clinical trial will look like when you are trialling psychedelic-assisted therapies. You have preparatory psychotherapy, as I said. You're preparing someone to how they will meet and engage with the content that comes up with them meaningfully. How to deal with challenging events. People go, oh my God, but what about the bad trip? For us as therapists, that can be sometimes the most therapeutically valuable stuff, actually, that we're looking for. And if people can engage with that meaningfully, that's when you can actually get more of that really lasting change. As my colleague likes to say, if you go to therapy and you're not feeling uncomfortable, it's a waste of money. The dose day itself, 6 to 8 hours. That's 1 day. But then the integration therapy, this is really important. What we're trying to do here is we're trying to understand how the insights that people have experienced, their challenges that they've faced, messages that they may have felt that they've received, or even just really peaceful, transcendent states, and how they can then go about re-accessing those states again and again and bring some of those insights and experiences and weave that into their everyday, so that then it applies to a broader context. It's not just that one day. They can then extend it to the broader areas of their life. So why psychedelic compounds? Why not antidepressants? Why not anti-anxiety? Why not antipsychotics? Well, those psychotropics do have a place. They do. They attenuate and can, alleviate distress, but it tends to sort of tend to it like this, and it quietens it down. It does not get to the core of what's going on. This blasts you into your own personal universe, but also it can do something that psychiatry actually has done very poorly, and that is that it can help you access the transcendent. And this is really profound for us, because we think that's how we can get a deeper, more enriching and more meaningful change for our patients. And particularly, I guess, in my cohort, we've got people who are dying and who are facing end of life. And I think, one of the things that I really like about this picture is that you're looking into the cosmos here, and the thing that, she's scrambling to get there. Now, for some people, staring into their own personal universe in this way, and having these transcendent type experience or mystical type experiences that are often described in literature, can be noetic, profound, very difficult to put words around. Important to also add, though, for some people it is terrifying. It's important to say this is not for everyone. We're working to trying to understand who this is for, how to optimise the treatments, and mitigate risk. But it's important to make sure that we understand that this can be a very, very powerful treatment, but it's not a universal outcome for everyone, and this is why we need to do some more research. But there is wonderful potential here, but yeah, not without some caution as well, because of the intensity of what we're asking people to do. Staring into your own universe, you don't actually know what's going to stare back at you. So I might shut up now and we can get on with the panel.
Thanks so much, Mark.
Thank you.
And we'll open it up now for debate. I've actually got a question for the audience before we start. Who here has read Michael Pollan's How to Change Your Mind? Hands up. That's everyone. Okay. It's unsurprising. It was a #1 New York Times bestseller. There's a documentary due out this year. But has that book massively raised expectations, got people excited for something that seems very imminent? Has it perhaps made psychedelic psychotherapy in particular seem a bit like a silver bullet? That's the question I want to kick off with. Anybody want to pick up with this?
Sure. It definitely has. I think at the moment we're seeing such a surge of interest. That was the other reason I really liked that picture, because that seems to be what's happening. We've got, to go back a little bit, when our trial was first announced, we were expecting enormous blowback. It didn't come. It went the other way, and it went the other way so... we were just completely blown away by the fact that it was just such a positive public response. Everyone wanted it. We were inundated with inquiries. We continue to be inundated with inquiries. Everyone's read Michael Pollan's book, and everyone has heard Joe Rogan. Everyone's talking about psychedelics at the moment. The difficulty, I think, that's some of the things that we're seeing is that there is an idea that if I just take the psychedelic, I can just lie back and it'll cure my anxiety or my depression. I can bypass the psychological work. And it's not the case at all. And unfortunately, that's a really problematic narrative, because then people are kind of arriving with this idea, I'm just going to take that, it's the miracle pill. You cannot bypass this work. It is bloody hard work. I have seen my patients guttural, heaving sobs, snot, facing really difficult terrain. And yes, that can be very therapeutic. But for some people who have had very traumatic histories, who have built a lifetime around avoiding, very painful memories or painful emotional states, to then kind of kick them into a psychic abyss is going to be very, very problematic. So we need to do some more talking about what this actually looks like and what this actually entails. It is hard work and it is intense. And yes, there can be a lot of gain from that, but it's important that we have realistic expectations going into this.
I'm happy to say a few words about that as well. I mean, I think the reality of modern life is that a lot of people do it extremely tough in terms of their mental health. And if you're seeking help, what's available? You go to your GP, 5-minute consult to unpack all the woes, the multiple woes and stresses in your life, and you walk out with a script. What does that script give you? Probably an SSRI. What are the chances that SSRI will help you? Probably 50-50 at best. It will also have serious side effects in terms of your sex life. It will flatten your mood. It might improve your mood, but good things won't feel as good. Bad things won't feel as bad. And then there's a whole bunch of other psychiatric drugs that were basically developed in the 50s, 60s, and 70s. Quite a few of the drugs that are most widely prescribed are older than I am. And that's saying something. And the efficacy we know is really poor. And I do a lot of work with psychiatrists, and they're all incredibly frustrated. The tools they have available for serious mental health conditions are very blunt instruments, and quite often they don't work at all. So it's long overdue that we have a paradigm shift. And so things like Michael Pollan's book are basically tapping into this huge unmet need, and the unmet need for radical new therapies that will transform the mental health struggles of probably half the planet, when we get down to it. So this is absolutely massive. There's an incredible appetite in psychiatry and in the broader community for change, but we also need to de-risk this approach as well. It's very new. The parameters are still getting worked out, and we're already getting quite a bit of pushback to Michael Pollan's book as well. In fact, people are accusing him of being too gung-ho, and that he needs to wind back some of the enthusiasm, because there are people out there that have suffered during psychedelic-assisted psychotherapy. That is increasingly clear.
It's the self-driving cars of mental health, right? Like everyone has this huge optimism in the space, and Michael Pollan's really promoted that, which is great. And certainly a lot of the founders, investors, non-profit advocates in this space, they'll tell you that they come to this problem from a personal mission and from experience with these substances. But I think about the patients who are in trials for things like treatment-resistant depression, who by definition have probably exhausted all of the other treatment options. If psilocybin doesn't work for them, that's a pretty desperate place to be, right?
And Sam, with Psylo, are you almost trying to predict and troubleshoot what issues could come up and be a few steps ahead?
Yeah, we're quite forward-thinking about everything that we're doing, and we're looking at agents that are sort of like a more broadly applicable psilocybin-like sort of drug, but also these other interesting classes of drugs where maybe it's a drug that's not fully psychedelic but has some of the same antidepressant effects, so you can take it a few times a week, so it's sort of like a next-gen antidepressant, as well as compounds that might not be psychedelic at all that can be taken and have some antidepressant effects. So yeah, we're always thinking about how to design these agents so we can sort of most broadly assist people.
Yeah, because right at the moment, using psilocybin is very costly because you need, it takes a long time. It's a long-lasting dose, so you can try and tweak things so, for instance, they don't last as long.
Yeah, most of the studies to date have been done with LSD and with psilocybin. LSD is about 10 to 12 hour duration, and the reason people use psilocybin is because it's about half as long as LSD. There's no dramatically different subjective effect of the two substances. A nice study very recently out of Switzerland showed that most people can't actually tell them apart from dose-related effects. So yeah, shorter duration of action is pretty important here.
Not according to the forums of Reddit. I'd like to ask you, Ian, actually, medicinal cannabis is kind of 6 years ahead of where we are now with psychedelics. Can we expect the same kind of trajectory, do you think?
Absolutely. I mean, we've been through all of this before. I'm almost too exhausted to think about doing it all over again with psychedelics. But yeah, back in 2015, obviously I mentioned Caitlin Lambert. But 2015, when we first met the Lamberts, there was no scheme for getting legal medicinal cannabis. So Caitlin Lambert's dad was bringing in an illegal product from Europe and ended up in Gosford District Court on charges for cannabis supply. He was doing what any father would do for a sick child, absolutely desperate in terms of the options, found something that worked, and the state of New South Wales rewarded that behaviour with criminal prosecution. I mean, we managed to get him off, but that's a different story. No one should have to go through that. The amazing thing is that in 2021, I believe, the medicine CBD that Caitlin Lambert was taking became available in the PBS in Australia. So it's actually now subsidised by the government. So you go from something that someone is dragged off to court for giving their child to something that's actually subsidised by the community in the space of 6 years. It's an incredible story. And that gives me a lot of hope, because that makes me think that we can do the same thing for psychedelics if the clinical trial evidence amasses that supports their use, if we work out the paradigm properly. And as I said in my little talk, I've been tremendously impressed actually with the Australian government. I'm not naturally a ScoMo fan or anything like that. quite the opposite, but we found very progressive thoughts around psychedelics in Canberra, and also medicinal cannabis. The champions of medicinal cannabis were not the people that you would imagine. It wasn't the radical left necessarily. We had Pauline Hanson on board. I had a very productive meeting with Tony Abbott. He thought medicinal cannabis was great. We politicians need to get out the friggin' way and let these doctors prescribe this to their patients. You know, it was tremendous. So it's not necessarily who you think, the more conservative voices. They all want better medicines for their families. They want everyone to feel better and do better in life. So we'll see how it goes.
Yeah, it's too early to say really with the Labour government what to expect, right?
Yes, I mean, I'm trying to organise some meetings as best I can, particularly on the cannabis front. Cannabis, as I showed in my talk, we have incredible accessibility now. We've got 100,000 patients who are getting legal medicinal cannabis in Australia. That will probably get up to about 300,000 by 2025. The major issue is for most of them, there's no PBS subsidy. And that reflects the fact that the clinical trial evidence to support efficacy is not there yet. People are getting prescribed medicinal cannabis for more than 130 different conditions. And we probably only have convincing evidence for 2 or 3 of them. But if you want medicinal cannabis for your ingrown toenail, for example, get a telehealth consultation with a cannabis clinic in Queensland, and the weed will arrive in the mail within a week. That's actually how easy it has become.
I was speaking to a patient very recently who was amazed. I won't say what their relationship is to me, but they were amazed that this is actually the case. It was about a week for a telehealth consultation for a legitimate pain and associated sleeping-related issue, and they had medicinal weed at their doorstep by express post within about a week, yeah.
I'm not saying it works for ingrown toenails, by the way. We don't have the clinical trial evidence for that yet.
Look, I'd love to talk about what psychedelic psychotherapy is realistically going to look like when it does get off the ground. So for a start, what is the likelihood that it will be rebatable through Medicare and thus, accessible to all?
Yeah, this one's me. All right. I think that the difficulty with it as it stands at the moment is that it's very labour intensive. You've got 2 therapists, then you accompany with your patient through through the screening, through the preparation phase, the dose day itself, which is several hours, and that's 2 therapists. That's a really costly day, and then integration therapy as well. Now, and the rule of thumb will probably look something like this: the more severe the mental illness, the more preparation that you're going to need, and the more integration you're also going to need as well, and the more dose sessions potentially. So that can be costly. One of the tensions, and it's difficult here, is that, and you can see this sort of in research at Imperial at the moment, they're really sort of trying to whittle down the number of prep sessions and integration sessions, which is really tricky, because then it means that people can be, less prepared, they have less integration. We know that there's been some coverage recently from, I think Cover Story was a podcast, people may have heard about it. One patient talked about an idea of, she'd gone through this therapy and actually felt like she'd had heart surgery because she wasn't quite stitched up enough afterwards because there wasn't enough integration. So we need to be really mindful that there's this difficult tension. If we've got too many sessions, it looks like it's too costly for the government. So they're trying to make it this sort of abbreviated package so that then it becomes more accessible. It's a quandary that is going to be a difficult one. I know there's some work now. Colleagues of mine in Baltimore who've just done some. They've just finished up a cancer study there, and they actually did groups. So they actually had 4 people at a time, but they had one therapist with each person, and then they did group integration, which continues, and they are doing tremendous work. So there's other models that we're looking at and continue to kind of, I guess, test and will be testing in the coming years. So, but I think that the key thing and the thing that keeps us up as therapists in this space is how we can make this accessible going forward for the people who most need it. Yeah.
And look, you mentioned Cover Story there, and I'd highly recommend you listen to it. It's a New York Magazine podcast with Symposia. They've been covering the many ways that, there's an opportunity for abuse and corruption and coercion within psychedelic psychotherapy, from rogue practitioners to, organizations offering training accreditation for drugs that haven't yet been approved, and we don't know when they will. Is this a sector that's ripe for exploitation? Any one of you free to go first?
I'm happy to say a couple of words. I mean, some of the stuff that came out of the MAPS trial, and my slide showed the Nature Medicine paper that provided what seemed to be quite convincing evidence around MDMA and PTSD. Some of the videos that have come to light from the Cover Story piece in New York Magazine show therapists, in bed with the patient, cuddling. And I think what this illustrates is that the psychotherapy component of psychedelic-assisted psychotherapy is not there yet. We don't know. I mean, there's very little evidence. Do you have 10 sessions? Do you have 2 sessions? Do you have 2 therapists? Do you have 1 therapist? Are you allowed to touch the patient? What does a psychedelic look like if there's no therapist? Do you actually need a psychedelic? What if we gave just a really high dose of cannabis once? Would that have a lasting effect on mood? If you take someone out of their body with any sort of psychoactive substance, will you get that reset that psychedelics produce? There's so many questions. It's quite bamboozling. And I think what we've arrived at is a paradigm that kind of works. It's evidence-based, but we did a lot more work on the type of psychotherapy, what's appropriate, what works, and how you can, as Mark says, whittle the cost down. Because the drug's going to be cheap. I mean, you only need to take it twice. It's not like an antidepressant that you have to take daily. The drug side should be quite inexpensive if it works, but the therapist part is going to be incredibly expensive if we do what you're doing at the moment, for example.
Yeah, and I want to pick up on that as well, because I think one of the things that we're starting to learn as this rolls out as well is that because of the therapy itself is really intense. It's not just a 1-hour session, which therapists like us are sort of used to before coming into this. It's several hours with your patient, and in really vulnerable circumstance, and they're in this altered state. It's powerful for the patient, but it's also really powerful for the therapist. So if you've got therapists that are walking into this that have got their own perhaps unmet dependency needs, and or they're quite a predatory character, and unfortunately that can happen. That can happen in therapy, just in general. And it can unfortunately attract quite predatory characters. And this is a problem. You need to have people who've got really good supervision, good therapy training, and that are not kind of beyond reproach. We all need to be accountable here, and it needs to be transparent work, I think, going forward.
Yeah, I think the whole Cover Story thing is very interesting, extremely relevant and quite problematic. But I think what was most surprising to me is that people think this is sort of isolated to psychedelic psychotherapy, when absolutely this goes on with dentistry, with anaesthetics, with other physicians who take advantage of patients in different contexts. Therapy alone without psychedelics. So I think the best way to resolve that is just with standardized training, standardized protocols, and different groups have approached this in different ways. And MAPS's protocol, because of the nature of that sort of study, multi-site, multi-center, it wasn't quite as standardized as it should have been maybe. And people have raised this as well. Apparently therapists were given quite a bit of leeway in terms of what was and was not acceptable. And that's quite a large problem in such a innovative but very experimental therapy.
So maybe there needs to be some regulating body.
For sure. Yeah.
What about the TGA? Hasn't downscheduled psilocybin and MDMA yet. Are they being conservative?
aren't they always?
Well, it's very interesting. I was just up with John Skerritt in the Sunshine Coast 2 weekends ago at a big kind of drug advocacy cannabis conference, United in Compassion. And John was very mellow compared to 5 years ago. I mean, he was really very pleased that people who wanted medicinal cannabis were getting it. He took credit for the fact that you can actually get cannabis plant material in Australia as part of a prescription, because the politicians weren't very keen on that. They thought it was okay to get oils and so on, but plant material they thought had a greater capacity for diversion and abuse. But John stood up to them. We didn't realize it at the time. So I think he's actually quite proud of the TGA's role. And I think, although I was a stern critic in the first 3 years of the medicinal cannabis scheme because it wasn't delivering, now we have quite a mature scheme that's almost the envy of the world. People are getting good quality product, and people who need the product are getting it as well. So you can't blame the TGA being cautious. I rashly predicted back in December that psilocybin and MDMA would be downscheduled, and I was completely wrong. But I think we'll probably get there. I mean, with cannabis, it was just really achieving that critical mass of evidence, as well as public pressure, advocacy, and enlightened voices suggesting that this is the right path to take.
Either of you want to add to that?
Not really. My personal feeling is that, the TGA generally errs on the side of caution. They follow what's happening in the rest of the world. If the FDA were to approve MDMA and or psilocybin in the next several years, I think they would reconsider their position in certain specific use cases for sure.
Yeah, I would agree. I think it's a tricky one. There's oh God, is this a hill I want to die on? It's complicated. I think at the minute, given what we've seen, unfortunately, overseas, is you can see how it can go pear-shaped if you don't have good regulatory processes in place, particularly for this therapy. I cannot stress the need for this. We need a kind of whether it be an independent body that can oversee things like training and standards, so that we're held accountable, actually. And so we're doing good ethical practice. You've got very... You're putting people in really vulnerable situations, so you want to make sure you're in good hands. I think that's important, and I hope that's in place soon so that we can get on with things like rescheduling. Yeah.
Might also, if I could just quickly interject, it might also have been a strategic mistake to try and downschedule MDMA and psilocybin in the one application. They're two very different drugs with different evidence bases. There's still a little bit of concern about toxicity with MDMA in terms of the brain serotonin system. They should have been done separately, and I wish they had been.
Okay, thank you. So with trials around the world going on at the moment, people with complex trauma histories, personality disorders are usually screened out because, it's a vulnerable sort of cohort, maybe too risky to deal with right now when you're trying to get things over the line. What do you think is going to happen once treatment centres actually are up and running and offering treatments? Will that screening continue, or do you think it will be open to everyone?
At the moment, because of the nature of clinical trials, they tend to be fairly cut and dried. There's, we're not looking at that, we're looking at this, we know there's a known risk, we're not going there. I think as we see trials move from phase 2 into phase 3, where they become multi-centre trials, when you've got hundreds, if not thousands of people, you may see more of a relaxing of those kind of inclusions and exclusions, but also just even of points of research interest in and of themselves. There is interest in, can we work more with complex trauma? It means that it would be a different protocol, perhaps, because obviously if you've got somebody who's got really, difficult and quite traumatic material to look at, again, once you've taken that psychedelic, you don't know what's going to come up. So having more time to then prepare people in a really systematic and graded way, and then more time to integrate, and they may need more dose sessions. So I think we're going to see more and more of a tailoring approach to try and optimise this for people who, really could benefit from this. But I think at the minute we may see more of I guess where we are in Australia anyway, more of that kind of the strict inclusion and exclusions unfortunately. We do know that there are people that is not good for. If you've got a history of psychosis or bipolar, particularly bipolar 1, we know that it means that you have a higher risk of relapse. As a serotonergic agent, it can trigger a manic episode in the same way that antidepressants can for someone who has that propensity. So we're being cautious. It's such a fragile re-entry back into medicine, which is why, because people are going, why are you being so cautious? It's because it's so easy for them to turn around and just shut this down again. We only need one awful kind of situation to happen, and then we could find ourselves back where we were in the 70s, where it was just completely given the kibosh. So yeah, we're doing it gradually, but we're doing it carefully so that we can get the stamp from the FDA. Then it's an approved treatment, and then that's it. It's an approved treatment. So it's available, but we sometimes have to be much more cautious and safe. Yeah.
There's a bit of a paradox there in that the people who are maybe most likely to benefit from it are least likely to get it in terms of the clinical trials because of the exclusion criteria. And it is a real issue. For example, in the panorexia trial that we're planning at the moment, we want people with anorexia nervosa who are treatment resistant, so in many ways the worst of the worst, and they have all sorts of comorbid health conditions. In many ways, it's a really high-risk study to manage. I mean, what does failure look like? And we grapple with these issues. And so in many ways, it is a calculated risk because you want to help people who can't be helped by any other interventions that we have at the moment. But as Marg says, these people are often the most fragile. And we wrestle with that. And I guess eternal vigilance and top quality clinicians involved in your trial and lots of risk assessment and safety-based procedures.
And look, talking of things that are hard to treat, I wanted to just touch on methamphetamine. It's something where I think there have been trials where milder stimulants have been brought in to try and treat it, but do you think people could benefit from psychedelic psychotherapy, or are you hopeful about other kind of trials that are on the horizon? Anyone?
Definitely,
yeah.
Definitely. And I think there's a chief principal investigator there he is over there, who is going to be leading a methamphetamine addiction study using psilocybin-assisted therapy. And I feel very proud to be part of that, and that's Dr. Jonathan Bresch from St Vincent's in Sydney. So that's due to commence very shortly. So yeah, we're really hopeful that can help interrupt the cycle of dependence and abuse that people are experiencing. So yeah, it's really, really exciting research, and I applaud Jono for taking the plunge.
I'd like to put in a plug for KNX 100, of course.
Yeah, go on.
So we get rats addicted to meth. They like meth even more than humans do. So don't think of meth addiction as a human weakness. It's not species specific. It goes throughout phylogeny. And so, yeah, rats will kill themselves on meth given half a chance, but you give them KNX 100 and for some strange reason they look normal, but they lose their interest in meth. It's one of the strangest things that I've ever seen. It may well be that if you upregulate social circuits, you become so attracted to being with other rats or humans, in our case, that the desire to take a drug that disappears, that you become... It's funny, I mean, MDMA is intensely pro-social, but doesn't necessarily lead to an attraction to all sorts of other drugs. And you don't necessarily want to do MDMA day after day after day after day, but if you're lucky, you'll get a long-term upregulation of social behavior. I've seen that in a few people with MDMA. The other one is CBD. We did a trial where we showed that CBD in high doses turned off meth-seeking behavior in animals, and we've been trying now for quite a few years to get a high-dose CBD trial up and running with people who have methamphetamine addiction. CBD in high doses is strongly antipsychotic, and one of the major problems with people who have meth addiction is that they become floridly psychotic, and a lot of that aggression comes from delusional beliefs about what other people are up to, and suspiciousness and paranoia. So I'd love to do that trial. In fact, I did a tour of South Australia and Victoria and Western Australian governments trying to drum up money for that, and didn't quite succeed. But maybe it's time to revisit that while we wait for KNX 100 to get on the market.
And I'm going to do an abrupt jump off topic because we're running out of time. But do businesses that are working on new substances, be it big pharma or be it startups, do they run into resentment from people who don't like the kind of monopolization and maybe kind of appropriation of what have long been considered spiritual medicines?
Constantly. Constantly. So, and I find it particularly infuriating because I view this as an organizational issue. I think pharma are probably the second or third most hated industry in the world after arms manufacturers and, I don't know, maybe nuclear power generators. But it's really misdirected. A lot of the resentment should really be directed towards sort of profit gouging health insurers who add very little value to the system. Drug developers play within the confines of this system that's very risk averse and very expensive. To bring a drug to market, depending on how you look at the numbers, and there's a few caveats here, but it costs about $1.3 billion is the recent estimate, USD. There is no other product on earth that you can develop that has that kind of like development timeline, risk profile, and costs so much to get into a human. And the benefit of that is that we end up with relatively safe and effective drugs. That's the whole point. So I think there's only been 2 cases I'm aware of where a non-profit has taken a drug all the way to market. 2 cases in the history of all approved drugs, hundreds of medicines. MAPS might become, the third. They're a non-profit trying to bring MDMA to market. But I think a lot of the resentment really is misguided. There's a lot of good people in this space. I know founders of a number of the largest commercial ventures in this area. They often come at it because they've treated their own depression with psilocybin. It's a pretty strong sort of North Star for a lot of people. I'm not an especially greedy person who's out there to make a lot of money. I've lost lots of friends to suicide. I think most people in this space, whether it's non-profit or for-profit, come at it from a desire to do good.
And I'm interested to talk about how reliant are you all on, private investment, angel investors, philanthropists, and should there be transparency on that front?
Should always be transparency, I think. Like financial transparency is generally a good thing. I mean, federal ICAC seems to be pretty popular at the moment, so it tells you people are definitely interested in federal transparency for sure.
Yeah, I mean, we, as an academic, I basically had 25 years of scrabbling around in the gutter trying to find 20 cents to run an experiment. That was the reality. And then I met the Lambert family, and my life was transformed. It was, at least for a little while, it was like winning scientific lotto. Suddenly you had the resources you need to run the experiments you need, and that's all we want. I mean, most of the scientists, I know, don't actually want heaps of money. They just actually want heaps of scientific discoveries. And the feeling that you get with serendipity, or we ran the clinical trial and it worked. If I found a talking frog, I wouldn't sell it for a lot of money. I would just keep it at home because, my God, it's a talking frog.
Look, before I throw open to questions, can you all, and I've given you this homework, recommend something for the audience for further reading, further viewing, something like that? I'm going to recommend something. You can find it on YouTube. It's called Drugs Lab, and it's filmed in Amsterdam, I think, and it's 3 young folk, and each week they basically road test a different drug, and it's in a really kitsch studio set up like a science lab, and one person will take it and the others will be their mate and listen, but they're all hooked up to machines, and it can be salvia, it can be cocaine. It's very interesting. So that's my recommendation. It's kind of a harm minimization idea so that people know what to expect. Sam?
I'd have to plug a 2-book series by one of my favorite scientists and authors, Alexander Shulgin. So as well as designing several hundred new psychedelics across 2 chemical classes, he actually did us all the service of writing a biography of himself and his wife and a number of his friends, and describing the design, synthesis, and activity of those hundreds of molecules. So you can actually go out and pick that up and You know, if you have access to a lab, make some of them yourself. I'm not encouraging you to do that. They're mostly illegal. But in theory, you know, he wanted this information to be available: structure-activity relationships, synthetic methods, activity profiles. So, and the first half is a biography, which is also pretty wild. He's lived a pretty interesting existence. So, Pical and Tical are the names of those books. Phenethylamines I have known and loved, and tryptamines I have known and loved.
Brilliant, thank you. Ian?
Well, you know, we just rediscover things that have already been discovered, don't we? So, I mean, going back to Huxley and the Doors of Perception, and also a very fine novel called The Island that he wrote, is incredibly instructive at this moment in history. Instead of doing pollen, or in addition to pollen, do some Huxley. And I love going out in the bush with my buds in and just listening to the huge profusion of wonderful podcasts that are available in this space. I'll put in a plug for Professor David Nutt, who we both work a bit with, and his Drug Science podcast, which has a really fine array of guests and psychedelic medicine, and a new episode just about every week. So that's probably quite a good place to start as well.
Yeah, good, thanks. Mark?
I want to thank Ian for pinching my book recommendation.
Sorry.
You know, it's interesting. I got fascinated, obviously, in psilocybin and then fungi in general, and read a beautiful book called Entangled Life by Melanie Sheldrake. It was gorgeous, a book about fungi, and it does talk about psilocybin as well, but it just, as a nature lover, it was an exquisite book. I've got a second one. Actually, I've got a third, because you picked my first one. But yeah, that one's a little bit more risque. Come and ask me if you want to know what that one is.
All right, well, look, I'm going to ask for some questions from the audience. So there's a mic there, just whoever's nearest it.
Hello. This one's for Margaret. For
Margaret.
those of us...
Oh, I'm Marg.
Marg?
I've
Okay.
never been a Margaret.
I'm sorry.
That's all right.
For those of us who are looking to get into the therapeutic space and
Yep.
become space holders,
Yes.
what would you recommend?
Good question, and I get it all the time. At the moment, what we're hoping to do is get a multidisciplinary approach. So not just psychologists and psychiatrists. We need people like social workers. We need, psych nurses who have psychotherapy training, psychotherapists who have got really good, solid training in being able to work with personality dynamic, I guess, in the room. So yeah, I think anything where you can get yourself a bachelor and do some good psychotherapy training is a really good start. Having, I guess, if you want to work in a treatment setting that's a hospital base, for example, like what I do, something that is APRA registerable is probably a good way to go. But yeah, we're hoping and we're working with a number of disciplines so that we can kind of start thinking about what that's going to look like. I don't have a specific course that I can tell you or courses, but definitely look into it. And I would say, yeah, something like, basic sort of degree, social work, psychology, psych nursing, even OT with psych training, and but yeah, a good reputable psychotherapy course is what I'll be looking at. Yeah.
Thank you very much.
Thank you.
Cheers.
In palliative care, with these experiences, what have you observed in terms of their transformation of their relationship to death and their acceptance of or fear of death? Like the kind of insights to what have you seen?
I love that question, and I really want to answer it. Because we're sort of mid-trial. So I'm going to just be really broad brushstroke here. There's something that Stan Groff wrote about. If people know who Stan Groff is, he was doing psychedelic research, and then when that stopped, he then went into sort of holotropic breathwork. But he did make a pretty remarkable discovery, and that was that he said that the way that people who are at end of life have psychedelic experiences are actually quite qualitatively different to people who are not at end of life. There is something about being kind of stripped back, and then you're facing your mortality, and you're really on the precipice there. And they can and tend to hit transcendent states quite quickly. And in a way that's actually quite powerful and can actually sometimes give a bit of ontological shock for people who perhaps don't have a framework of understanding these really kind of powerful experiences. What else can I say? The rest is difficult to describe because it has no words. I think we are also we also struggle to find words as
Ineffable.
therapists, and and what we witness. But I think certainly feeling the connectedness to something bigger than this, connected to the natural world, feeling as though that they're sort of part of some kind of life cycle of life and death, and that's okay. There does seem to be a very powerful peace and letting go. Yeah.
So I imagine some would think something happens after death, and others would think that there's nothing.
Mm-hmm.
You're saying it's not either of those two, just acceptance of either of those two?
Well, it's sort of everything and anything. It's really hard to sort of, it's so individual. It's so individual. But, for us, however that person, experiences that, that's their personal experience. So, yeah, it's difficult. Some people will go, oh, I think that there's life after death. Some people go, no, I don't think there's anything. I think I'm food for worms. Whatever it is for them, we want them to try and come to a point of feeling peace and an ability to kind of let go. Yeah.
Hey guys, it's really awesome work you guys are doing. This is just sort of to everyone. Ian mentioned the clear moral issue with criminalising the Lambert family member, I forgot who specifically that was, for doing what any father would do in regards to supplying their daughter with cannabis. But what about psychedelics? Are people who self-medicate with psychedelics in the absence of a therapist because their life lacks the transcendent, as Marg said, or for any other reason that they desire, are those people deserving of persecution? If not, then what are the implications for drug policy? Thank you.
It's an excellent question, and it's a kind of recapitulation of what we've done with medicinal cannabis over the last 6 or 7 years. The Lambert Initiative has been involved in countless cases where people have been involved in compassionate supply of medicinal cannabis compounds to family members or complete strangers. I mean, we have helped medicine men and women who've been posting out cannabis oil to people who are suffering and who've ended up on criminal charges. So I think I would differentiate psychedelic medicines in that regard. If you're self-medicating existential angst or end of life, as a lot of people were with medicinal cannabis before it became readily accessible, then that's a perfectly humane and acceptable strategy to be involved in.
Yeah, and it's not uncommon, unfortunately, in the way that, that people have to kind of, that they don't want to break the law. They just want relief. So, yeah, it's but completely understandable when they're so stripped of options, but not something we endorse because of the illegality of it, and I don't endorse anyone getting arrested. But, yeah.
Victimless crime, I think is what you call it.
Hi. Firstly, I want to thank you all. It's been an amazing session. My question is along the same lines. So what would it mean for your work to have these drugs decriminalised? Would it be beneficial? Would it be detrimental? Would it be neutral? Second part of this question is, would your work be easier if you had anecdotal evidence of people in society who have benefited or suffered as a result of these drugs?
I can answer the second one from medicinal cannabis. That's how we work. That's how we roll at the Lambert Initiative. We go out and we speak to patients and we get their stories and we get incredible leads in terms of beneficial effects that we take back to the lab. One very brief example, we worked with, I think, 70 families who were illegally giving cannabis oils to their severely epileptic children. And we provided support to them, and we learned about their lived experience. But we also took their oils back to the lab and analysed them for what was in them, and we were able to get an efficacy signal, which we then took into cells and mice and fish and learn a lot more and actually validate their use with their children, because the same things they were using for their kids were, anticonvulsant in mice. And we were also able to show that there was very little by way of pesticides or other toxins in the oils that were being used, which was an important safety signal as well. So that's one example, but basically that's what we do. We look for signals out in the community, bring them back to the lab and try and understand them mechanistically. I'll let someone else answer the first part of the question.
Yeah.
I mean, I have pretty strong opinions, outspoken opinions on this, but I think all drugs should be decriminalised. I think there's no benefit to the criminalisation of drugs. We allow, as David Nutt will say, we allow people to do all sorts of risky activities. You can ride a horse, you can shoot a gun, you can drive a car. We just encourage education, training, regulation. I don't really understand why drugs have been criminalised. I mean, I do understand it quite well, and it's very politically convenient for control of different socioeconomic groups in society. It's not really a criminal issue at all, except by artifice.
I'll just jump in and mention, actually, on June 23rd, there is a forum hosted by a Stan Grant, Is It Time to Legalise Drugs? So if you want to go deeper into that topic, that's put on by Support Don't Punish. So I think for us to deal with that would be another few hours, but we will take maybe two more.
Hi, I have a question regarding, particularly to everyone, but I think Dr. Banister, you've touched a lot on it, and I see you're very passionate about it. Given that drugs have been criminalised for political purposes to target, particularly LSDs and psychedelics, to target race, as well as that the role which pharmaceutical companies like Purdue play in pushing drugs onto the populace, what's the role that individuals like you guys, good-willed people with high stakes in psychedelic research and implementation, play in ensuring that other companies and other startups for mental health and psychedelics remain within ethical and moral boundaries?
Yeah, it's a really good question, and I think it really depends on the individual and on the organisations that they're working with. The Purdue Pharma story is an interesting one, and it just goes to show you can absolutely sell drugs to people as long as you play by a certain set of rules. I think most people, this space is so small and it's growing and emerging at the moment. Most people are driven by this sort of personal mission that we've touched on previously, and I think it's just something that needs to be considered as the whole industry continues to grow.
All right, I think I've got so many hands, but I think we've got time for one more. I'm sorry.
Thank you very much for all of your contributions. It's been a wonderful discussion. I just wanted to ask a couple of questions around the clinical trial process. So in terms of using psilocybin to measure outcomes like depression in palliative setting, what kind of endpoints are you using to measure success?
Yeah.
Is it self-reported, and does that contribute to the problem of demonstrating to the broader community that there is efficacy? And then secondly, you mentioned that it's used in combination with psychotherapy.
Yeah.
Obviously, you can control the amount of psilocybin that you're using, but not necessarily the quality of the psychotherapy.
Absolutely.
So how does that work in the clinical trial process?
Oh, God, I've only got 2 minutes.
Sorry.
Can I go back to your first question again? So it was about... Sorry.
So it's endpoints in the clinical trial?
Yeah. So I had this fascinating question that was asked of me and my colleague, Dr. Justin Dwyer, the other day. We just finished a session, actually 2 sessions. This young woman who had profound experiences, and she turned around and she asked me, "How are you going to write this up?" And I burst out laughing because I was like, how do you compress, I've got 40 incredible people that we're going to have at the end of the day. How can you aggregate 40 universes into numbers? It's so absurd. The clinician in me just finds that just absurd and aggravating. And also, having heard these remarkable stories, and I've got to crunch that into numbers on a checklist, because that's what the FDA likes. Now again, that can demonstrate change, and that has been able to sort of demonstrate change. We're doing mixed methods. We want to give people their own words. So a lot of what we do is, as well as you're going, can you check that? But we want to hear, what was it like for you? What did you experience? How has this helped you? What was most meaningful? What was the role of music? Here's another therapist. There's 4 therapists in that room. There's 2 of us, the psilocybin and the music. That's another thing. So, How am I going to write? I don't know. I'm going to do it the normal way, and that is how a clinical trial. It will be analysed. We're analysing from using qualitative research as well as quantitative research. So we've got mixed methods because we want to give this the best way of kind of illustrating and describing what happens for our people that undertake this. But it is very difficult. And when you're talking about psychiatric research or psychotherapy research, that's a whole other ballgame again. You've got your set, we've got the preparatory therapy, we've got the dose day, we've got integration therapy, we've got manuals that kind of tell you what you need to be covering in each session. Aside from that, it then I guess it becomes down, to the art of psychotherapy and the therapists themselves and the individual content that person brings. So in some way, it's always going to be individual for that particular person that's sitting in front of you in that time. We just have to aggregate it. But it's a very good question, thank you, but it's not an easy one to answer, and it's not an easy one to address with methodological rigour, but we do our best. Yeah.
They're horrible straitjackets, clinical trials.
They really
they really force you down this very narrow road that you often don't want to follow, but for some reason that is the gold standard evidence. And hopefully the human brain will develop to the point where we don't need them anymore, and there'll be some much more enlightened way of gathering high-quality clinical evidence. I would just add to what Marg said that there's a massive issue with placebos in psychedelic trials. What does a placebo look like?
Nocebo.
What drug do you think you're on? Are you communing with the little men in Pluto yet? Or so we agonise over that quite a bit, and a lot of thought about active placebos. Drugs that give you some kind of transcendental state but aren't psilocybin. We were looking at high doses of THC at the moment as perhaps an interesting control for psilocybin in clinical trials. So a lot of thought going on, but if you've got any ideas for something that could replace clinical trials, I'd be all ears.
I'm so sorry we have to wrap it up because we could talk all night. We had a few Zoom calls in the lead up and I was like, we're never going to be able to contain this. Your questions have been fantastic. Before I wrap it, I just want to let you know about a couple of kind of related events you might be interested in. So next Friday, June 9th, I'll be back. This time at the Australian Museum, but it's to interview journalists and TV makers, Bridget Delaney and Benjamin Law, about the wellness industry. And then on the 12th of June, right here, we've got Dying Well with virtual reality filmmaker Lynette Woolworth and two doctors who guide those at the end of their lives. So that might be of interest as well. But if you could join me in thanking Ian, Sam and Marg for coming here and sharing their knowledge. And don't forget to party on at the bar next door. That's it. Thank you.